Hello everyone, today's topic is primary health care. Let's first identify what the primary care is. Primary care is the first level of professional care where people present their health problems and where the majority of population's curative and preventive health needs are satisfied. Primary care is a general care, focused on the person as a whole instead of on one specific organ or health problem. The mix of disciplines that make up primary care workforce may differ from country to country, but general practice or family practice is often considered to be the core of primary care. Besides general practitioners or family practitioners, the most common primary care providers are general nurses, general pediatricians, pharmacists, primary care nurses, physiotherapists, podiatrists, home care workers, and mental health care professionals. Primary care is facing high expectations. It is expected that primary care can help health systems become more responsive to changing health needs, offer more integrated care delivery, and increase the efficiency of the system overall. Decision makers are searching for models to redesign primary care systems in line with these promises. Primary health care is there for you throughout your life. It's been from birth to the final days of life. Primary health care covers the majority of person's health needs. It's promotion, prevention, treatment, rehabilitation, and palliation. I would like us to watch WHO videos which talk about what the primary health care is.
Primary healthcare meets the majority of people's health needs during their life. It welcomes a child into this world, providing services like vaccines that protect us and our communities against infectious diseases. Primary healthcare supports us through childhood, adolescence, and adulthood, with services to keep us healthy, like guidance on good nutrition and physical activity habits. It keeps a close eye on risk factors, runs diagnostic tests, and can confirm a number of diagnoses right in your local community, be it at a rural midwife post, family doctor practice, city clinic with a group of doctors, a social worker in a community centre, or a pharmacist on the corner of your street. Primary healthcare also treats and manages a number of conditions through regular follow-up care, prescription medications, and further prevention, including chronic conditions such as hypertension, diabetes, and asthma, in addition to mental health and urgent care needs. Primary healthcare provides services for people of all ages to take charge of their health and confidently manage their needs in partnership with their regular health providers, family members, and caregivers. It meets the majority of our health needs during our life and even accompanies us into old age, adding life to years and years to lives. Primary healthcare needs our support, just as it supports us.
Yeah. So firstly, we're going to talk about primary care in European countries. We're going to see their example. Then we're going to talk about the primary care in Singapore, because Singapore health system is one of the best in the world. So health sector reforms in many European countries have been driven by common challenges related to financial constraints, changing health rights, and mobility, workforce developments, and growing possibilities of technology. These developments, which have diverse influences both on demand side and supply side, from healthcare systems to adaptations and improving responsiveness to current health needs of the populations. When we say financial constraints, we mean that there are negative consequences of reductions in public spending on healthcare. In many European countries, because of the 2008 crisis, there were frozen or cut health budgets, especially affecting the hospital sector and pharmaceutical care. Sometimes salaries of healthcare workers were reduced. As the crisis unfolded in several countries, changes were also made in the scope or breadth of health coverage, for instance by creating or expanding user charge for certain services. It seems that the economic crisis of 2008 has also resulted in healthier behaviors and a reduction of risky behaviors. For example, deaths from traffic accidents have been falling in many countries. What about the changing demand? Well, it has often been ascribed to the aging of populations in most European countries. Indeed, the effect of aging on healthcare demand is important, but should not be overestimated. People today and the near future will not just become older than previous generations, they will also reach high age in good health. so that on age-related morbidity and demand from the past should not simply be extrapolated. Most important challenges on the demand side are related to the epistemological transition in Europe and the indirect effects of demographic developments. These are the growing prevalence of non-communicable diseases and the increase of more complex demand, resulting from high rates of multimorbidity. Healthcare systems, which are traditionally designed to manage acute episodes of one illness, need more integrated provision of services and health facilities as well as in the community. In addition to change in curative care, prevention and health promotion will become more important to increase healthy life years. If primary care maintains a continuing relationship with patient and rotation throughout the community, it can be well positioned to provide preventive services and health promotion. But it's what happens actually in normal, regular days. But situations like we have today, when the whole planet, government, and health system fighting the COVID-19, what a primary health care should do in this case? Well, we're going to see example of UK. We're going to see their guidance in it. The aims are to identify potential new cases of COVID-19 and isolated patients to reduce onward transmission or if safely to the hospital is severely unwell. There could be several conditions where you can suspect that person have COVID-19. Well, first, person with one or more of cough, fever, breathless symptoms. If the person returned from a high risky country in the 14 days before the onset of symptoms, or he had contact with a confirmed case of COVID-19 infection. Actually, nowadays, it doesn't matter which country the person come back, he should be actually isolated for 14 days. Well, this is the situations, and if the person, as a patient, identified in general practice surgery during the consultation, he need to be isolated, but to make it, you need to bring consultation to a close. Firstly, avoid direct to physical contact and exposure to respiratory secretions. Advise patient to call National Health Service from within the consultation room. Leave the room and close the door. Wash hands thoroughly with soap and water. When this will you find out the situation at the reception. Again, ask patient to return home immediately and contact National Service. If they do not feel well enough or are unwilling to leave, they should immediately be isolated. You need to have isolation room in primary health care center, and you need to prepare it in advance. When you plan, please plan which room is most appropriate for isolation. First, it should be located away from waiting areas and other consultation rooms, without curtain floors or certain furnishing, close to separate toilet facility. When we say isolation room, what there should be and how you should act. First, close the door. Do not enter room, reassure and update patient by telephone. Clean and disinfect hot surfaces and usable care equipment after patient leaves. Cleaners should wear personal protective equipment. In the room, you should turn off conditioning and open the window and dispose of all waste in a clinical waste bag. Personal protective equipment in primary care, it's actually same almost everywhere. A standard surgical mask, gloves, apron. You should wear them if contact with the patient is avoidable, and for cleaning the isolation room afterwards, you should use that. And for sure, dispose of personal protective equipment as clinical waste after use. But if a person get a telephone consultation, in this case, assess whether clinically stable. Initial data indicate that patients display approximately this proportion of severity, 80% with no or mild symptoms. If that kind of case, advise patients to contact the National Service and advise them to self-isolation. If 15% severe disease or 5% critical and well, ask them call 39 is for UK, inform operators that patient may have COVID-19 and alert local infection specialists. If person should make self-isolation, so what kind of conditions he should be and how he or she should act. Stay indoors for 14 days, separate from the rest of the household. Double bag, wait for test results before disposal. Choose a well-ventilated room. Wear clean masks in shared kitchen. Use separate paper and cutlery. Do not invite visitors for sure. Use separate bathroom or clean shared bathroom regularly and use separate towels. Numbers that you see here is for UK, but for Azerbaijan, if you feel one or more of these symptoms, or if you have, you were in contact with a person who have COVID-19 and you again have these symptoms, and you're living in Azerbaijan, you live in Baku, please call 103. If you live outside of Baku, in Azerbaijan, please call 113 and you will definitely get help. Well, there's therapeutic options for COVID-19 related severe acute respiratory distress syndrome. There's therapy and implementation, which could be advised to the doctors who work in primary health care, is the way that you see on the presentation. Okay, is what I want to talk about what the primary health care centers, what the primary health care workers should do, and what the primary health care should do when there's a case of COVID-19. Let's come back to the primary care where we discuss the demand of primary care, which may also change as a result of changing role of hospitals. Supported by technology innovation, hospital stays will generally be shorter and more complex care will be provided in the community. Finally, demand for care is likely to change as patients move from relatively passive recipients of care to more active and well-informed care consumers. Thus, development of patient empowerment will encourage people to have the capacity to take an active part in their own health and disease management. Patient empowerment, new electronic resources, and the internet may reduce the information asymmetry between professional and patient. Well, the relationship between patient empowerment and health will definitely give better healthcare outcomes. When it comes to change on the supply side of healthcare, which are consequences of policies to enhance the role of primary care, as well as developments in the healthcare workforce, primary care requires new skill mixes and professionals capable of fulfilling new tasks in the current structure. Multidisciplinary team practices is a response to the need for new models of care delivery. Major trends in skill mix development are the enhancement of the role of nurses and extension of primary care teams, either in shared premises or in networks. New tasks for nurses can be transferred from other health professionals versus physicians. Examples of such tasks are monitoring of chronic disease, delivering prescriptions as specified in protocols and medical procedures, such as taking cervical smears. Primary care teams may be extended to include new functions, such as nurse practitioners or new specialized on community health or prevention. Collaborative networks may include a large variety of teams and healthcare workers together, providing a broad, integrated set of healthcare services, for instance, for patients with chronic conditions. Offering general practitioners more possibilities to work in teams may also help to solve another issue on the supply side: shortage. In a number of countries, there are concerns about the availability of sufficient general practitioners in the forthcoming years, in particular because the workforce is aging and general practice is not attractive enough to require sufficient numbers of medical students. For young general practitioners who want a working environment that allows a good balance between work and private life, independent single-handed practice may not be a favorable choice. Creating more team-based practices in primary care may help recruit more medical students to become general practitioners. For example, in France, where there's a tradition of single-hand practice, a national plan has been successful in increasing the number of group practices and multidisciplinary maison de santé in primary care. The plan has also contracted threatening shortage in underserved areas. A seemingly easy remedy for healthcare workforce shortage is to rely on immigration of healthcare workers. Two types of healthcare workers flows can be identified in Europe. One, within the European Union, from newly to older member states, for example, from the Czech Republic to Germany or from Romania to France and Italy, And a second one from outside the European Union, for example, from India and Pakistan to the United Kingdom, and from Western Africa and Maghreb to France. Important issues that come along with migration are the formal recognition of foreign education, as well as communication problems that may arise from different languages or cultures. Relying on migration may have profound effects on healthcare systems in the donor countries, and it may be questioned whether a structural solution to shortages. Advancing technology. Advancing technology creates a mix of challenges in health care. Advanced information technologies will enable medical record systems to create database for population-based working, which is relevant for prevention and more integrated collaboration with the public health sector. The impact of medical technology has so far been most dominant in hospitals, but it's likely that it will be sweeping in primary care and home care as well. It's not just healthcare providers who will be users of medical technology. Patients too will benefit from new, small, and smart technology. As expanding care options will undoubtedly put pressure on healthcare budgets, decision makers may need to take measures to avoid uncontrolled increase in expenditures. For primary care, the development of specialized tests for use in general practitioners' practice will be relevant, such as rapid office-based laboratory tests or near-patient tests. Furthermore, portable pulmonary function testing has the potential to enhance the quality of follow-up and patient adherence to treatment for chronic respiratory disease. Miniaturization of ultrasound scanners may give real-time imaging assessments without any risk to patients. Tests that were formerly exclusively hospital-based, such as 24 electrocardiogram monitoring, may allow patients to undertake those exams at home. Enhanced diagnostic and possibilities for follow-up in ambulatory care setting may further increase the autonomy of primary care. The development of telemedicine may create the opportunity to operate remote technical procedures or clinical collaborative work. Telemedicine can facilitate access to primary care, practice of specialist advice in real time, which will improve services delivery in rural areas or in the context of scarce human resources. Strong primary care is often associated with a gatekeeping position of general practitioners. However, the strength of primary care is based on more characteristics than this one alone. The essential role of primary care is as towards the whole healthcare system, which requires that it should preferably be offered in a community where people are living without any physical, psychological, or financial barriers whatsoever. Furthermore, a generous and patient-centered approach is essential, and also that the medical history and the living situation of patients are taken into account. If necessary, patients can be referred to a medical specialist or hospital. The general practitioner will guide the patient through the referral process and the healthcare systems. However, the large majority of health problems and diseases that patients present can be handled within primary care. Therefore, a broad set of treatment services should be provided who are in touch with one another. In addition to, or in combination with, treatment, tailored health education and prevention can be offered. To improve adherence to treatment plans and preventive programs, continuity of care is also important. Last but not least, whereas the patient is moving through the healthcare system, an overview needs to be kept and treatment and follow-up need to be coordinated. The more a primary health care system manages profile, the stronger it is. It is widely believed that a well-developed system of primary care has beneficial effects for sure on the healthcare system as a whole. Systems with a strong primary care level appear to be better able to control costs for sure and have better health outcomes. Recent evidence shows that strong primary care is associated with better population health, but lower rates of unnecessary hospitalization and relatively lower socioeconomic inequality. However, actually, overall health expenditures is higher in countries with strong primary care structures. Over the past 2 decades, most fundamental healthcare reforms have taken place in the countries of Central and Eastern Europe. They previously belonged to the former Soviet bloc. The old symmetrical types of healthcare system had to be redeveloped. In these countries, primary care development has been an answer to the challenges of creating more effective and responsive healthcare systems. A number of countries introduced a primary care system with family doctors in a gatekeeping position, thus bypassing countries in Western Europe that have painfully sought to make one of the steps toward a strong position for primary care. In countries that didn't experience such as profound social transmission, reforms have been more incremental, and in these countries, no fundamental change have been realized in the relative positions of primary care and the secondary and hospital sector. But in the early 1990s, primary care had been recognized in a small and fragmented way, and where access to hospitals was relatively easy, this situation basically continued to exist. Primary care can be conceived as a subsystem of overall healthcare system, with a special focus on the facilitation of the access and association of coordinating services for the benefit of population's health. For reasons of measurability, this general characterization should be elaborated. Based on the results of a symmetric review, primary care has been unraveled into 10 essential ingredients called dimensions, which have been ordered into 3 groups, those related to the structure, to the process, and to the outcome of care, respectively, as you see on the graphic. The structured dimensions refer to the basic conditions that enable a good functioning of primary care, consisting of relevant policies and regulations, as well as the availability of financial, human, and material resources. Well, let's first talk about the structure group of dimension includes. This consists from governance, governmental vision of primary care and pro-primary care regulation there, economic conditions, about exposure on primary care, incentive and remuneration systems. Workforce development is about positioning of primary care workers and professional associations. The dimensions process level include access to services, its geographical distribution and physical access to the facilities. This continuity of care is about the patient during a practitioner relationship, continuity over time as well. Coordination of care is gatekeeping role for general practitioners and teamwork. Comprehensive of care, available medical equipment, breadth of service profile. The dimension related to outcomes include quality of care. It's about the prescribing behavior and chronic disease management. Efficiency of care is about the practice management. Equity in health it includes difference related to social status or gender. In Europe, as a next step in making the dimensions measurable, an extensive set of indicators was developed for the FAMIU, Primary Healthcare Activity Monitor for Europe study. This European Primary Care Activity Monitor, it's made that a symmetrical literature review was undertaken to identify the key dimensions of primary care. Each dimension was broken down into a number of key attributes, which were called features. To work out the features, identify the systematic literature review, a provisional long list of measurable indicators was made. Then the select publications were searched for operationalization of the features. Furthermore, International Database, Organization for Economic Cooperation and Development, Health Data, WHO Health for All Database, Eurostat, World Bank, HNP Stat, European Union Public Health Information and Knowledge. I'll leave a link if you want to go and see and read about it more. First, search for ready-made indicators. For features where no operationalization was found, the research team developed measurable indicators. The long list of indicators was evaluated on relevance, precision, flexibility, and discriminating power, as well as for their suitability for describing and comparing primary care systems across countries in Europe. Well, I should note that additional relevant sources were found in the European organizations and networks in primary care, such as regularly updated health system centralization publications of the European Observatory on Health System and Policies, and other international scientific publications. For sure, these international sources were complemented by national sources. National experts were consulted to obtain access to great literature or articles in a language unknown to the members of the project team and to validate the country results. In absence of reaching sources, opinions of experts could be used instead. If you don't know what the great literature is, let me give a short explanation. Well, it's usually understood to mean literature that's not formally published in sources such as books or journal articles, that which is produced on all levels of government, academics, business, and industry in print and electronic format, but which is not controlled by commercial publishers. Grey is mean deep, it's between white and black one. And you know what is a white one, right? It's published journals, books, professional society, conference proceedings, and ideas, concepts, and so are black one. Okay, let's come back to primary care. To determine the strength of primary care, country data on all indicators but transformed the scores indicating the level of primary care orientation of healthcare systems, ranging from 1, low primary care orientation, to 3, high primary care orientation. The rating of qualitative indicators was derived from the findings of the systematic literature review. For example, if an expert for primary care policy was in place that country received the score 3 for that indicator. Similarly, if general practitioners were paid a mix of fee-for-services, capitation, and performance payment, this was considered as a primary care strengthening incentive structure as the country received a 3 of the respective indicators. The way primary care is structured establishes important conditions for both the process of care and its outcomes. So let's discuss 3 dimensions: governance, economic conditions, and workforce development. Let's begin with the governance. Governance belonging to the dimensions of structure mentioned in the primary care framework. We see previous involves a complex of features of forced implementation at different levels. Definition of government by Kerhans is a set of principles, norms, roles, and decision-making procedures around which actors converge in a given public policy arena. Furthermore, concepts derived from the regime theory are used, such as outcomes, in the form of quality management of infrastructure. The existence of a juridical support background includes laws and regulations, and the existence of administrative practice that constrain, prescribe, or enables the provision of services. We're gonna work on a table as which you see on the presentation, and let's go through it. The rebuild of an expert government vision of the role of primary care, the healthcare system is among indicators of governance. A vision on current and future primary care has been identified as far as it has been explicitly laid down in policy documents. Such visions on primary care were not always available. They were poorly developed, in particular in Austria, Belgium, Czech Republic, Germany, Hungary, Iceland, Latvia, Poland, Slovakia, Sweden, and Switzerland. Let me go through. So here and here. Yeah. In a number of countries, visions were focused on partial reforms of primary care systems. This was the case of Cyprus, Finland, Ireland, Italy, Portugal, Romania. And journal research shows that countries with a gatekeeping system produce more formal governmental pro-primary care policies and vice versa. Furthermore, the characteristics of the type of health systems in the countries, such as social health insurance or the National Health Service, were not found to be related to the extent that supportive primary care policies were in place. One of the most consistent policy characteristics in countries with strong primary care is the government attempts to use resources equitably and avoid inequities. And there's a small number of countries, including Estonia, Hungary, Latvia, Malta, Slovakia, and Switzerland, responsibilities for primary care have been centralized at national level. In other countries, essential functions such as priority setting, financing, supply planning, and management, as you can see here, provision of services or quality monitoring are the responsibility of regional or local authorities or regional health insurance funds, hospitals, or primary care trusts. Countries where the most functions in primary care have been decentralized are Denmark, Italy, Norway, Spain, and Sweden. In Malta, Norway, and Romania, decentralization of primary care has been included as a system target. Possible advantage of decentralization is the existence of inequalities in policies and eventual access to and the quality of primary care. Some countries where important responsibilities for primary care have been decentralized have national policy to ensure an even distribution of providers and services. Such explicit national policies are not in place, however, in Czech Republic, Finland, Greece, Iceland, Norway, Poland, and Turkey. When it comes to responsiveness of healthcare systems, they can be facilitated either through stakeholder involvement in policy development or by community participation in the organization and provision of services. In most countries, stakeholders as a community are involved in some way in these issues. In Cyprus, Italy, Luxembourg, and Malta, only one form accused, while neither one accused in Hungary and Slovakia. Aspects of patient rights, such as informed consent, come back, yeah. Aspects of patient rights, such as informed consent for treatment, the possibility of patients having access to their own medical records, regulation on confidential use of medical records, and the ability of patient complaint procedures in primary care facilities have a legal basis in all countries except Cyprus, France, Iceland, Ireland, Luxembourg, Malta, and Switzerland. The least protected patient rights in these countries is the availability of patient complaint procedures. Quality assurance by means of formal medical education requirements for providers to work in primary care is in place in all countries. However, Cyprus, Finland, and Hungary are more lenient with these requirements in the shortage of supply, allowing non-specialized physicians to practice in primary care. In addition to personal educational requirements, to practice in most countries' primary care facilities needed permission to operate. Such permissions are not required, however, in Belgium, Finland, France, Germany, Ireland, Luxembourg, and Norway. Quality assurance to the development of evidence-based clinical guidelines. The general practitioners exist in all countries except Ireland, Malta, and Switzerland. Usually, such guidelines have been produced by a combination of stakeholders, including ministries of health, a college, or association of general practitioners, and medical specialists. Sometimes foreign guidelines are used and adapted for the national situation. So we have the figure here that shows that in most countries, governance structure aiming to enhance the commitment towards primary care are relatively well developed. Furthermore, consistency among countries can be identified in the score of the various indicators. From Netherlands to Lithuania, and the figure can observe the countries with a strong primary care governance. The group of countries with the weakest primary care governance begin from Switzerland, continues until Poland. The other countries hold an intermediate position on primary care governance. Here's economic conditions. Economic conditions of primary care, which is the second structure dimension from the framework, are largely determined by the proportion of total health expenditure spent on primary care and the financial conditions for access to care for patients. Co-sharing and co-payment can threaten equity in financial access to care. Furthermore, financial incentive for healthcare workers can play a role. Primary care professionals can be salaried or self-employed providers, either contracted or not to the health service or health insurance system. The employment status and mode of remuneration may also influence the attractiveness of primary care professions. Primary care expenditure strongly varies among countries. To some extent, this results from the service included in the expenditure for primary care. A uniform methodology for calculating primary care expenditure across the countries is not available, and this hampers the comparability of this indicator. For example, in some countries, it's limited to costs for family practice only, while other freely accessible specialist care services are also included. Additionally, costs for community nursing, primary mental health, tertiary, and emergency care may be included in primary care costs. Even in family practice, phone holding elements for laboratory tests and other investigations can be included. Finally, uniformity in the allocation of costs of prescribing medicine is absent. Well, from the figure, that provides an overview of the total economic condition of primary care scores by country, considering the performance of each country on all economic condition indicators. The figure shows that the general economic conditions of primary care are almost favorable in Belgium, Denmark, Finland, Germany, as in Italy, Netherlands, Portugal, Slovenia, Spain, and the United Kingdom. Countries where economic conditions for primary care are relatively poor are Bulgaria, Cyprus, the Czech Republic, Greece, Iceland, Ireland, Malta, Romania, Sweden, and Turkey. Concerning the income of providers, major observations is a considerable gap in most countries between the financial status of primary care providers compared to hospital specialists. The only countries where the general practitioners have a financial status comparable to medical specialists are Cyprus, Czech Republic, Hungary, Ireland, Portugal, Spain, and the United Kingdom. In all other countries, the income of general practitioners is usually considerably lower than the income of most medical specialists. However, in these countries, general practitioners earn considerably more than nurses and allied healthcare professionals. Well, what about work development? Workforce development, the third dimension of the governance framework, refers to the profile of professionals providing primary care services and their position in the healthcare system. Important elements are, for example, the type of healthcare workers involved in primary care, their gender and age structure, and their professional recognition among other medical professions. For future continuity of general practitioners and other disciplines in primary care, the availability and quality of vocational training schemes, maintenance of an attractive profession, and rotation of workers are important. Being prepared for future workforce needs implies quantitative and qualitative capacity planning. Professional development and defense of the interests of primary care workers can largely be attributed to academic departments, professional colleges, and associations. Facilitated by governments, these can also be involved in quality assurance, research, and continuing medical education. Well, if we look at a table which provides an overview of results of primary care workforce development by country, we'll see that there's active in primary care and talk about it. So we need to say that the only primary care professionals that were found in each of the 31 countries included in the study are general practitioners, also referred to as family physicians. On average, there are 68 general practitioners per 100,000 population in Europe. Also, the variation is very large. The contrast between the neighboring countries, Belgium and Netherlands, is very large. In Netherlands, the number of general practitioners per 100,000 population is 47, while there are 150 per 100,000 in Belgium. Also, dentists belong to primary care in most 27 countries. Also, quite common in primary care are nurses. They are legal disciplines in 23 countries. However, nurses may have quite different roles in primary care. They are varying from specific nursing tasks, for instance, with chronic patients, to more general support tasks. Specialized nurses and home care nurses are less prevalent as part of the primary care workforce, in almost half of the countries only. In 22 countries, midwives are working in primary care. Well, furthermore, in many countries, patients have direct access to a number of medical specialists, and so they are also part of primary care. In 2/3 of the countries, gynecologists, pediatricians, and ophthalmologists are considered as primary care professions. In about half of the countries, specialists of internal medicine, ENT specialists, cardiologists, neurologists, and surgeons are active in primary care providers. What about availability of general practitioners? Aging among general practitioners may become a problem in many countries. In well over half of the country studies are available, our institutes are working in primary care demography and future capacity needs. The expectation of Turkey, where the average age is 39 years, general practitioners in the remaining countries are mostly between 45 and 55 years. Again, the age distribution varies strongly from one country to another. In countries like Cyprus, Czech Republic, Italy, Norway, Spain, and Sweden, around half of the general practice workforce is over 55 years old. Countries seem to react differently to the immediate effect of the aging of their general practitioners. In some countries, number of general practitioners has strongly increased in recent years, such as Greece, Lithuania, Poland, and Slovenia. In addition to the age structure of the profession, workforce capacity is also related to the opening hours of practice and working hours of staff. The opening hours of general practice across Europe, excluding possible hours on call, vary from 35 hours per week in Hungary to 100 per week in rural Austria. The average, we can see Hungary here, and Austria here. The average is 44 hours a week. These hours include post-direct patient care and other activities. In some countries, opening hours are subject to mandatory regulation, which also applies to general practitioners who are self-employed and work with their own practices. Well, relatively high levels of primary care workforce development are found in Denmark, as we see in figure, Finland, Ireland, Malta, Netherlands, Portugal, Slovenia, Spain, Switzerland, and the United Kingdom. Workforce development is low in Cyprus, the Czech Republic, Greece, Iceland, Latvia, Luxembourg, Malta, Poland, Slovakia, Slovenia, and Sweden. Each dimension has been depicted. Each dimension here we see each dimension figure has been depicted and acted as a figure. It's about the overall from high, medium, low level of governance, workforce development, and economic conditions, primary care by country. We see here that which with each pair of dimensions, governance plus workforce development, governance plus economic conditions, workforce development plus economic conditions. The position of a country has been visualized. The darker the shade of green, the stronger the position of a country is in the figure that you're seeing. Countries with a strong primary care structure include governance, economic conditions, and workforce development. They are Denmark, Finland, Italy, Netherlands, Portugal, Romania, Slovenia, Spain, and the United Kingdom. A relatively weak primary care structure on the three dimensions is found in Bulgaria, Cyprus, the Czech Republic, Greece, Iceland, Luxembourg, Poland, and Slovakia. No consistent patterns of primary care structure could be identified in Estonia, Norway, and Switzerland. Let's talk the delivery of primary care services. Well, it's about the process actually, and the focus on institutional features of service delivery in primary care. The access to service, continuity, and coordination of care. In addition to the volume and type of primary care services, accessibility is determined by the remoteness of services and the practice organization. Its appointment system, after-hours care arrangements, home visits. Financial barriers such as co-payments determine the financial accessibility of primary care. The extent to which access to primary care services is provided on the basis of health needs without systematic differences on the basis of individual or social characteristics indicate the level of equality in access that's achieved. Continuity of care is about the comprehensive relationship and management continuity. The coordination function reflects the ability of primary care providers to coordinate the use of services within primary care and other levels of healthcare. It's determined by the presence of gatekeeping system, practice structure, and teamwork, diversification and substitution of primary care providers, integration and collaboration of primary care with secondary and the public health sector. When we are paying attention to overall comprehensiveness of service by country, it's clear that with all niches combined, there are only small differences between countries. From the figure, we could see that primary care services are most comprehensive in Lithuania, Norway, Bulgaria, Belgium, United Kingdom, Spain, Finland, Sweden, Portugal, and France. A narrow profile was found in Slovakia, Italy, Greece, Cyprus, Romania, Hungary, Poland, the Netherlands, Slovenia, the Czech Republic, and Austria. The other countries were in an intermediate position regarding comprehensiveness of primary care services. So in the figure, all dimensions of primary care service delivery posts have been taken together. And Denmark, Spain, and the United Kingdom have a high accessibility of primary care. I won't see as the overall level of accessibility coordination primary care by country. So this is figure, we could see that. And when I'm saying Denmark, Spain, and the United Kingdom, and I want to notice that they have a high accessibility of primary care, provide a relatively high level of continuity and coordination of primary care, and provide the most comprehensive scope of primary care services. Countries where accessibility, continuity, coordination, and comprehensiveness of primary care are somewhat less constant are Estonia, Lithuania, Portugal, to less degree medium level, the Czech Republic, Finland, and Poland. Austria and Cyprus have a relatively weak primary care service delivery process, considering all four dimensions for sure. Consistent in a lower weak medium in Bulgaria, Italy, Luxembourg, Romania, and Turkey, and to a lesser degree medium level in Greece, Ireland, Malta, and Switzerland. The less constant among the dimensions of services delivery was found in the remaining 11 countries. Well, overall, the scores of the four dimensions of the primary care services delivery process show no associations with each other. Each of the primary care dimensions is positively associated with primary care accessibility, and for excess economic conditions to 0.54. In addition, coordinating with primary care is positively associated with primary care governance and primary care workforce development. So I would like to list the conclusions which were made by family project-related service delivery in primary care in Europe. Well, first, it was that obstacles to access were related to shortage of general practitioners, which were usually more possible in rural areas than towns and cities. Geographical equality is not optimal in most countries. In general, access outside normal office hours is differently organized, and most countries are typically non-practice based, which may be unfavorable for continuity of care. Homebound patients in countries where general practitioners rarely make home visits may experience difficulties in receiving the care they need. Also, most countries have no financial barriers for visiting a general practitioner. Home visits and prescriptions were more often subject to private payments. Major conditions for continuity of care are well-kept medical records for patients and general practitioners being responsible and accountable for care provided to a defined practice population. Such patient lists were mandatory for all patients in two-thirds of the countries. In general, differences between countries and continuity were modest. On coordination, differences were larger and countries performed less well. A gatekeeping system was operational in only a quarter of the countries. Also, in other, partial gatekeeping system was in place, or at least there were incentives for patients to achieve the same effect. Solo practice, which is less favorable for coordination, was still the dominant mode of practice in almost half of the countries. Collaboration between general practitioners and medical specialists was an area for improvement in many countries, and the links between primary care and public health were poorly developed. In the countries where general practice had a strong role as a doctor, at first contact, they treated more than 19% of all patient contacts without referral. Regarding the provision of medical procedures and prevention, the variation was large. These task domains were less developed. We've talked about the primary care in Europe, so I would like us to talk about the primary care in Singapore as well, because one of the best healthcare systems in the world is Singapore health system. So that's why I would like to talk about primary care in this country. First of all, let's talk about the strategy. The Ministry of Health has exposed a strategic vision based on three key shifts that will drive the healthcare sector in the coming years. The first of these is related to our topic. It's about to go beyond hospital to community, fostering the full spectrum of service delivery outside acute care throughout not just primary care but the robust long-term care sector, as well as community-based models of care. The supply side expansion of primary and community care will continue under the Health Safe Work Plan 2012 and beyond, and be supported by the planned rollout of National Community Nursing Program. What about these days? Well, let's look what happening there until now. In 2017, it was announced that 6 regional health systems will be further reorganized into 3 integrated clusters: Singapore Health Services, the National Healthcare Group, and National University Health System, each offering a fully comprehensive suite of services encompassing acute, primary, and community care. The initial concept of the regional health systems was intended to enable patient-centered care, promote newly integrated clinical pathways and care coordinators, work with multidisciplinary teams of the patient's lifetime. Subsequent strengthening for enablers and linkage between providers have furthered this aim, including efforts to integrate specialist outpatient clinics and primary care providers to improve chronic disease management and community-based care. For example, the Frontier Family Medicine Clinic and National University Hospital formed a partnership to allow follow-up of chronic and specialist outpatient care at clinics rather than hospitals. Supported by data linkage, primary care physicians of the Frontier Family Medicine Clinic were able to access appropriate patient information of the National University Hospital and facilitate shared care, resulting in fewer appointments, more continuous care, and system-level savings. Also in 2017, there were 2,102 registered primary care clinics and 20 public polyclinics, and they're planning to build more in coming years. Recognize that a strong primary care sector is critical to managing non-communicable disease in an aging population. The chronic disease management program was first introduced in 2006 for diabetes, hypertension, hyperlipidemia, and stroke. Today, the program covers 20 chronic diseases. The program coordinates systematic, evidence-based chronic disease management programs across 700 general practice clinics and groups, and enables the use of Medisave to cover these conditions. I will give you explanation what the Medisave is, and other 3 M's that they call. Its financing mechanisms. So in Singapore, there are 3 statutory financing mechanisms, the 3 M's, are central to finance the remaining portion: Medisave, Medishield Life, and Medifund. Implemented in 1984, Medisave is a mandatory medical savings account financed from payroll deductions, which can be used by an individual or their immediate family to pay for hospitalization, day surgery, and approved outpatient expenses. What about Medishield Life? Well, it's a universal health insurance scheme that provides lifelong catastrophic cover for large hospitalization bills and selected special outpatient treatments, chemotherapy, kidney dialysis. Supplemental coverage can be purchased in the form of private integrated shield plans and riders. So premiums for Medishield Life and integrated shield plans can be paid using Medisave. Finally, the Medical Endowment Fund, or Medifund, is an endowment set aside to support those in financial difficulty even after subsidies. This Medifund actually implemented in 1993. Endowment fund set up by the government as a safety net to help poor and indigenous Singaporeans pay for their medical care. Acts as a last resort for patients who, despite heavy government subsidies, Medisave and Medishield, are unable to pay for their medical expenses. Patients receiving inpatient treatment in Class B2 and C, both are subsidies outpatient. And this was about the 3M. I just want to let you know that. Well, as Singapore prepares for the impact of aging, the definition of resilience was widened to include efforts to build capacity to address the long-term threat of chronic diseases. Efforts that prevention are being scaled up to reduce future downstream costs. This includes large-scale efforts at health promotion, such as a continuing commitment to the National STEPS Challenge, the War on Diabetes, and Screen for Life. The National Screening Program, while continuing to upgrade this hospital infrastructure, including the recent addition of new co-located general and community hospitals, Singapore is refocusing on primary care, on primary and community-based care, building family medicine clinics and community health centers, and increasing nursing home beds and places for center and home-based care. I would like to show you a video made by National Health Group, which clearly demonstrates what kind of help you can get in polyclinic and what you should do when you arrive there. So we talk about the primary care in Europe and in Singapore. I would like to briefly give you information about the global conference. The primary care leaders, government, ministers, development partners, civil society, and young people, they all meet in October 2018 in Astana for the global conference on primary care, which are actually hosted by the government of Kazakhstan, UNICEF, and WHO. Participants there, they renew their commitment to primary care as means of achieving universal health coverage, the third suitable development goal, and other suitable development goals to which health is contributing factor. This conference is marked 14 years since the first global conference on primary health care, held in 1917 in Almaty, then Almata, Kazakhstan. The Declaration of Almata endorsed that conference was a seminal document that founded a movement and advocacy for primary health care. The 2018 conference was a new declaration of Astana which emphasizes the critical role of primary health care in promoting good health, social and economic development, and global security. It aims to reinforce efforts to ensure that everyone, everywhere can enjoy their right to the highest standard of health. At the end, I would like to say that primary health care includes three core elements: affordable and accessible health services, including quality primary care and essential public health functions that promote health and well-being, prevent illnesses and protect population against outbreaks of disease. Empowered people and engaged communities to whom health services are accountable and who are also responsible for their own health. Inputs in policies, actions, resources from all sectors that influence health and well-being, ranging from agriculture, manufacturing, education, water, sanitation and hygiene, transport, and the media. As is stated on WHO poster, primary health care is the most efficient and effective way to achieve health for all. But too often, the most under-resourced part of the health system with the biggest gaps in poorer and marginalized communities. We must act now to ensure no one is left behind. It's actually all. I'm leaving here for your references. It's a books and links that will be useful for you. Thank you and bye.